Welcome to the Redefine Health Ed Podcast. I'm your host, Dr. Katie Obright, and we're going to talk all things primary care PT. Enjoy the episode. Okay, so hi everybody. We are at episode 5, believe it or not, of the primary care PT series, which I'm really excited to have Dr. Todd Davenport with us today. So for those of you who don't know of him, which probably a lot of people listening to this podcast already know of him, but for those of you who don't, I'm just going to share his bio really quick. Dr. Davenport serves as a tenured full professor in the DPT program at the University of the Pacific in Stockton, California. Dr. Davenport is a graduate of the University of Southern California's DPT and Orthopedic Physical Therapy residency programs. I didn't know that. I didn't know you were a USC graduate. Dr. Davenport's scholarly interests include diagnostic reasoning, physical therapy practice, as well as program planning and evaluation as they relate to the prevention of injuries and chronic diseases. Dr. Davenport has authored articles describing clinical reasoning processes for the symptom-based diagnosis of pathology by physical therapists in order to determine the appropriateness of physical therapy and guide intervention. In addition to his academic and service work, Dr. Davenport practices at the Kaiser Permanente Stockton, California Medical Office, which is what I really want to talk about today, as well as some of the community-based programs that you've been involved in. So Todd, thanks for coming on the show today.
My gosh, thanks for having me. This is really exciting. I've been wanting to do this. This is really cool.
Yes, awesome. So tell us a little bit about kind of how you started with Kaiser and how the primary care thing came to be in your background.
Yeah, in my residency program, I had some really solid mentors who really stressed being an autonomous member of the healthcare team, but that also we should be actively involved with making sure the people who present to our clinics are meant to be there, that we're the most appropriate providers to be able to work with them. And so just too many mentors to name, but in particular, Dr. Hugh Watts, who's a pediatric orthopedic surgeon, was one of our residency mentors who really spent a lot of time with the process of teaching us the process of making a diagnosis, even so far as to give us feedback on our history taking subjective examination, and just really formative mentorship there. Of course, we then rolled that into some post-residency experiences. I wrote a research paper, wrote an editorial about the physical therapist role in symptom-based diagnosis. And then we put together a textbook that described this process of symptom-based diagnosis for physical therapists. And so it was really focused on helping people learn competencies and skills and clinical reasoning in order to be able to sort of do that thing. And then sort of later on evolved into other aspects of primary care, which is sort of the prevention of sort of risk factor management, prevention of chronic non-communicable diseases, and got very interested in the physical therapist role in that. And it was part of the reason why the MPH was so important later in my career, to sort of help me build out an understanding of what that looks like. And so, yeah, here we are talking, I guess.
Yeah, awesome. So I want to know a little bit more about, do you think that when you started all of this, do you think that you and your thought process was more disruptive? And by me saying that, I'm saying you're going against the grain of what the traditional model or the traditional trajectory of PT was like. So I kind of want you to explain your thought process on that question.
Yeah, I think early on, I mean, you sort of get into these experiences and you sort of think what you think, and you kind of have folks around who are helping you develop your thought processes, and everyone's kind of, I don't want to say like-minded. It's not an echo chamber, but it's, there's some consensus on what that looks like. And then you put an editorial out in the world describing that viewpoint, and you realize that, there's some difference of opinion there. And that, maybe I kicked the beehive a little bit with that, where I really didn't expect that should have been controversial. Mm-hmm. And so there was a brief editorial exchange kind of back and forth, and sort of trying to contextualize the physical therapist role in sort of symptom-based diagnosis, making a diagnosis, clinical reasoning at the level of pathology and pathophysiology. And I think it was a really good conversation, kind of back and forth. How do we balance the concern about being kind of experts in the human movement system and thinking about how we might make assessments at the level of the movement system? How do we contextualize our efforts with regard to how common these diagnoses are encountered in practice? Do we prepare just for the once in a career, or do we prepare for what's most common throughout a career? And so there's some really good, I think, really solid exchange of viewpoints in there. And I think probably this is before the social media thing where you have a take and you put your take up on like Twitter or whatever, and people like respond to it either positively or negatively. And so this was before social media. So I wouldn't classify my thing as a take, maybe, but I think maybe there are people that would. So now there's like that immediate feedback, but before it was like, wow, yeah, you don't know where you stand until you put your ideas out there. So
yeah. So give me the timeline of like when did you publish that paper?
Oh God, that was like a long time ago. 2005, I think.
Ish. So almost 20 years ago at this point.
Yeah. Wow,
we're creeping up there.
Yeah.
So
thanks.
I'm actually really interested in how you think that the PT world has responded to that over time and where we are today, because I'll tell you from my experience, I think 100%, like we can't practice direct access unless we know how to go through the differential diagnosis process. Mm-hmm. I've been practicing that from the beginning of my career, which was in 2014. And I will hold that and take ownership of that no matter what. So I live in Illinois now, where the Practice Act is like, I don't know, it's weird. It's weird because it's like we can see patients direct access. But there's something in there about, and my interpretation of it, which maybe I should check with the Attorney General of Illinois, but I'm not actually going to do that. My interpretation of it is, yeah, we're not performing or giving medical diagnoses. Like I'm not diagnosing somebody with multiple myeloma. But if something's inside my scope of practice, then I'm certainly making a diagnosis. So I'm curious, how do you think that the evolution of this has taken place since you published that first paper?
Yeah, I think the viewpoint got less controversial because, as you pointed out, there are just more people who maybe have been educated in that manner to think that it's more acceptable. I think direct access laws now are more common. And so while there's like role conflicts in there, so this podcast is not legal advice.
100%. 100%.
but we sort of now have this expectation and some facility and comfort with thinking about pathology and labeling pathology, in as much as we're going to use those labels for communication. Mm-hmm. I'm not trying to treat cancer, but I sure would like to know if it is potentially present so I can get that person to the right provider at the right time for the right assessment and treatment. And I would like to be able to use that word. Hey, I'm concerned about that this person may have symptoms and signs associated with a certain type of cancer. Mm-hmm. I think that should be appropriate. But as you point out, our direct access laws are really public protections laws, and so but they're incoherent. So we have this. They've decided that direct access is fine, but that we can't, in California, we can't diagnose medical disease. It's very specific in our Practice Act. So diagnosis is really two things. Diagnosis is a thought process, first of all, clinical reasoning process.
Right.
Commonly call it differential diagnosis, and it's a process of labeling. And so basically our Practice Acts are against us providing a label. Mm-hmm. I hope to God it's not illegal to think, so let's not outlaw thinking. There's not enough of that happening. But, at the end of the day, like, how are you going to use this thought, the end result, the end product of this thought process, if you can't do a provisional label? 100%. It's very inefficient to try and communicate by charades.
Yes.
Or listing out a whole bunch of findings and hope that people will just like get it.
Right.
Because even a referring provider or a healthcare practitioner who's a diagnostician may not get it. So
Right.
we're like playing charades back and forth trying to make it work, and so it's very inefficient. And I really hope that as these practice acts with direct access provisions sunset, that we really put some thought into
Mm-hmm.
how it is that we can use diagnostic reasoning and labeling for communication.
Mm-hmm.
That's something that hasn't changed since 2005. But
Right.
I think informally, people are pretty comfortable with this whole idea of differential diagnosis, and not so much using specific maybe screening techniques, but maybe using more patient-centered, hypothesis-oriented algorithms in order to identify potential underlying pathology for both physical therapy treatment, because we use pathology, sort of information in our own treatments to inform our own treatment plans, but also to help refer out.
Yeah, absolutely. And I think that more DPT programs in schools are like entry-level programs are teaching, the hypothetical deductive reasoning. I know when I teach it in my primary care course, I make sure that I talk about, diagnosis is an evolving process. Sometimes something is not going to declare itself on day one. And so that's why you have to be vigilant, with watchful waiting and that kind of thing throughout each session that you see a patient. So great information on that. I would love to move into a little bit more about your experience in the Kaiser model. This is a primary care series. So the people that I've interviewed so far have been in integrated primary care settings, and those all have different definitions. So I want to hear a little bit more about your experience there.
So Kaiser is a large closed health system. And so that implies a given patient population of membership and a certain payment model. And so I bring that up front because I think the success and failure of many primary care physical therapy programs and initiatives have sort of like come and gone based on this payment and referral requirement kind of tail wagging the dog of how we provide care instead of the other way around. Mm-hmm. So I really think I want to bring that up and make that very, very clear first for folks who are listening in. The primary care model at Kaiser started in the 90s and was brought forward as a potential solution to reduce access times into the physical therapy department. By at first embedding physical therapists into primary care environments. And so the program came about initially helping physical therapists upskill into this differential diagnosis and providing more acute care advice, doing more health promotion, health coaching, in order to get people started with programs that would work instead of, sort of like more of a consultative service instead of more of a rehab service where we would see people, potentially for longer periods of time, and for sort of longer plans of care. So that went forward at Kaiser in, I think it was Hayward and Union City, California. So East San Francisco Bay Area, and was done for a number of years and sort of was disseminated into different areas within Kaiser. And I think everywhere it was picked up, it was interpreted a little bit differently. So bear in mind that California is a modified direct access state. Our direct access legislation is still relatively new, even though it may be, almost 10 years old now. And that physical therapy referrals within the Kaiser system are considered specialist referrals, and so those need to come from traditionally come from a primary care provider or a physician. So because just of how we're viewed within the system. So our roving here in the Central Valley of California typically has consisted of relatively short visits, short consultative visits at the referral of a physician. And ultimately what we're doing is we're trying to get people on the right track, for acute symptom management. It tends to work pretty well. We have some data that we're trying to gather and to try and share out on this model. So while it's not a pure direct access model, it's kind of a modified direct access model. It's kind of an upstream physical therapy model.
Yep.
There's a lot of communication back and forth with the physician about, yeah, maybe physical therapy isn't super appropriate for this patient at this time for X, Y, and Z reasons. And maybe we recommend a referral to this service before they start physical therapy, or, alongside physical therapy, it might be a good idea to get X,
right,
X intervention and so forth. So we're very much, I hope, helpful in that decision-making process and working side by side with our physician colleagues.
Yeah, I think that so you're describing a very similar model. It's been consistent that the other locations that I've interviewed, whether it's VA or other civilian type settings, they are promoting this consultative role in primary care with these, warm handoffs, or a primary care physician or provider comes up to the physical therapist and says, hey, we have this patient, this is what's going on. Like, what do you think? Mm-hmm. And so I think that the advantage of it, even though it's not like the patient is directly triaged to see you first, I actually think that the advantage of this type of program is having physical therapy and primary care providers in the same space at the same time, working to improve the outcomes of the same patients. Mm-hmm. And that the benefit and the advantage of the providers just all being in the same place at the same time is really for the advantage of everybody. And I will, from my experience, when I was integrated in primary care, that was the best job I ever had. I learned so much from them. They told me that they learned so much from me. Everybody's benefiting, especially the patient at the end of the day. Absolutely. So it doesn't even necessarily matter that choose PT first. Like the PT has to be the first person to see the patient. It's way less about that and way more about this team collaboration that takes place. Would you agree?
Yeah. And there's this expression that's kind of thrown around sports that it's amazing what you can accomplish when you don't care who gets the credit. And I know that there's there's limits to that, of course, and there are boundaries of professional license, and there are important considerations with regard to who gets to do what and who gets paid for what.
Sure.
But at the end of the day, if you sort of make your service oriented around the patient, a lot of these solutions just sort of drop out of that orientation of just doing what's right for people.
Mm-hmm. Okay, so now that we know what that looks like, well, let me back up a little bit. How much time would you say that when you're in the integrated primary care model at Kaiser, how much time do you spend with an average patient? How many patients are you seeing a day, give or take?
Well, I'm probably one of the worst barometers for that because as an academic, I'm a day a week in the clinic and I have other responsibilities. But, within half a day, I might see patients in a block on about every 15 minutes. So they're fast consults. People are late, they come early. And so there's some play within that. But there's in a consultative visit, you're not doing an entire plan of care. You can't do an entire plan of care. You're just doing health education, health promotion, health coaching. And so it's important to kind of keep that in mind that the requirements for examination and the requirements for documentation should be different.
Yep.
In your consultative visits versus your kind of full-length rehab visits, which kind of walks into a challenge that I find that people in the fee-for-service environment have of how do you get paid for all this, exactly. Which I'm not going to pretend to know, but again, This is like symptomatic of the tail wagging the dog. And I'm very, I don't mean to be dismissive of the concern. I'm actually really sympathetic to it. But again, it's just sort of a reality of conducting a business in healthcare. So probably within that 15-minute visit, there's about 5 minutes for just sort of getting a quick update. Most of the documentation is available from the primary care physician, but I like people to tell their own stories, Give me the elevator pitch, what's happening. Why are you here? Just kind of getting a sense of what the patient's expectations are. And then usually there's some brief exam to at least confirm the physician's or disconfirm the physician's initial hypothesis and referral diagnosis to make sure we're on the right track. And then the rest of the visit is really towards health education and generating written materials and and so forth in order to ensure success, and really arranging for follow-up. So in a consultative model, this is not just like a one and done, goodbye, never see you again, but utilizing the technology that's emerging that we have to make sure we send a follow-up email and so forth, and make sure that people get the service they need and make the progress that they want. Because on the back end, you have to have a plan. If they're not getting better with what it is that you're doing, even though natural history is on our side with a lot of conditions, you need to make sure that you get folks taken care of.
Yep, absolutely. Okay, so I love this conversation because it's echoing a lot of the other primary care conversations. So, and I love that because we know now that there is consistency regardless of the type of setting. There's consistency, at least in the model. The payment, like you mentioned, especially in fee-for-service model, is definitely a barrier because the way that typical insurance companies view us is rehab professionals. They're not yet used to us performing these more consultative type doing these consultative type visits. So that can be, I have some resources and some things in the works for that, but we won't talk too much about that today. I also want to talk to you and hear more about, I know that you're involved, or you have been involved in getting some free clinics or community care clinics established with this type of team-based model. Can you tell us a little bit about that?
Yeah, I was for a hot minute there. I was involved with a community medical clinic that served primarily folks in kind of the Medicaid space, folks who are unsheltered, and a population of undocumented immigrants and so forth. So there was that, and really the consultative model worked well with the warm handoffs. In fact, it was great because, here one of my patients would push his shopping cart full of bottles across the city to come in because he could find a place that was safe for him to put a shopping cart while he was getting medical treatment. And he wouldn't have just sort of walked across town for one thing. He knew that he was going to come in and see a PT for his knee problem from being on his feet all day, finding and pushing these bottles around. So just different societal problems and pressures. The payment model is very much, it depends, of course. There are HMO-based Medicaid programs, but for the most part, we were contracted through a fee-for-service Medicaid insurance provider, so that payment model looked a little different. And so, but the consultative approach was really, I think, effective to kind of help get people on the right track, and folks that don't ordinarily have the resources to be able to come into a clinic, and certainly wouldn't have the resources to be able to afford most rehabilitative approaches. The consultative approach was a good way to get started.
Awesome. So that's great information. And I will sort of echo my experience when I was adjunct faculty at Pitt for a little while when we lived in Pittsburgh. And I oversaw some of the students in their free clinic there. And it was great. It was all in one location. There's, physicians and PAs. There's, I think there was nursing students also there. They had pharmacy, they had PT, OT. I'm probably missing a lot of other things, but they had all of these services available in one location. And it was really great for all of these patients with unique needs. And I think they also provided transportation, or they were able to arrange for transportation. For anybody interested in learning more about that, and specifically about the PACE program, which is a Medicare and Medicaid service, listen to episode 2 with Kelly Schrader. That was an awesome, very enlightening conversation. So Todd, what do you tell your students about primary care? I know you teach in the program. So what are current DPT students in 2022 learning about what they can do in primary care PT?
Yeah. So I might be a little unusual, and again, maybe still swimming upstream a bit, but I try and let my students know that they're always in primary care, no matter where they are. They may be in the most tertiary setting, feel the most insulated. Their patients and clients may be worked up the wazoo, but they're always in primary care.
100%.
we have an ethical obligation to make sure that we're the appropriate provider for patients. And so we should take that seriously every time we see the patient, every time we email them, every time we call them. So that's the first message they get from me. And then they get the idea, as you mentioned a little bit earlier in the episode here, that this isn't just sort of an initial evaluation piece. This is throughout the episode of care, and even after you discharge them and they call you back with some ache, pain, rash, or what have you. Mm-hmm. And so you're constantly, your head is on a swivel using these skills. Mm-hmm. And that, I sort of bring primary care back into my population health course that I give for our students here in the way of identifying risk factors, risk factor management, and also mitigating social determinants of health, mm-hmm. which, as you look at our colleagues over on the physician side in primary care, family practice, general medicine, internal medicine, that's what they're doing. They're doing a lot of this. And so we really have a space there to be able to open up towards thinking about risk factor management. Mm-hmm. But it's, the nuts and bolts. It's, here's the information from your pathophysiology class, but we're going to flip it upside down. So maybe before you had like a ton of, here's what the pathology is and maybe just a little bit of signs and symptoms. Now we're going to flip it upside down. So you get lots of signs and symptoms and maybe just reminding you what that pathophysiology is. Mm-hmm. There's a lot of thought press. I do a ton of case-based learning with the students. Mm-hmm. We have a case every week. Where we go through, and they're cases that are sort of across symptoms across the lifespan to try and help people have confidence and competence with coming up with the kinds of questions to ask, the kinds of diagnostic hypotheses to have, how to sort of rule them more and less likely, how to communicate that in an elevator pitch to to a physician, to a psychologist, psychiatrist, a nutritionist. Making a referral, how do you make that referral? And so we spend a lot of time doing that.
We are 100% on the same page. I don't teach DPT students for the most part. I'm adjunct faculty in a few programs, but my population that I teach to is mostly clinicians out there, and I am teaching the same concepts. The big things that we can really have an impact on as a PT profession are these issues and these diseases that are affecting our population health. I mean, what is the first line treatment for somebody who is pre-diabetic or pre-hypertensive? It's exercise and lifestyle change. And if we can be part, we're a small piece in a big medical pie. But if we, every time we see a patient, are thinking about risk factors for cardiovascular disease, risk factors for other cancer and other types of non-communicable diseases. If we can identify those risk factors, communicate them to a patient, and we'll treat your shoulder for sure. But I want you to be aware of how can we make sure that pain in your shoulder isn't coming from or isn't going to lead you into a downward spiral of disability and inactivity. Educating on the global and the bigger importance of just remaining active, staying healthy, making sure you're sleeping and eating well, making sure you have access to good food and transportation and money to have those things. So really thinking big picture about the complete patient every time, every patient, no matter what. That's what I like. And I'm so glad to hear that you are teaching that as well. And I hope that everybody's teaching that. So thank you for.
Yeah, definitely awesome points. And I'll just sort of throw in there in the manner of swimming upstream, because it's kind of been on my mind lately, mm-hmm. that every time I see an e-blast for, our advocacy that, a certain insurance company is behaving poorly because their compensation they're providing PTs is reducing. Anytime I see, they've changed the way we can bill units, to their advantage, and we're going to start seeing cuts in our payment. I just wonder if we're just trying to do the wrong things better.
I agree with you.
I wonder if we're trying to do the wrong things better. And I wonder if we adopt this approach of, if nobody cares who gets the credit, imagine what we can do. And we need to start advocating for models that allow us to practice at the top of our license. I don't think it's an accident that upstream and primary care models are easiest to pull off and most incentivized in closed health systems like the VA and Kaiser. I don't think that's an accident. And so I would love to sit down and talk with our capitalist friends who are trying to thrive within a dying fee-for-service model, and ask them about how it is we can change their minds and get them to start thinking about increasing health equity, increasing, sort of health payment, whatever health plan for all you want to incentivize. That's how we're going to be able to practice to the top of our licenses.
Mm-hmm. I'm with you, Todd. I'm 100% with you. And it's really my career mission to see PTs not only just get into this setting, actually getting integrated there, but to thrive in this setting and to, and to change this downward spiral of burnout that we all know everybody is feeling and experiencing in the fee-for-service model. So thanks so much. Any parting words of wisdom? Where can people find your textbook? How can they communicate with you?
Textbook through FA Davis. And we probably throw a link on social media about that.
I'll put it in the show notes.
Amazon. Gosh, I don't know. You can find me on Twitter. I'm at Suns Opening Band until Elon implodes it. And then I need to figure out where I'm going to go. But in closing, I just want to wish you a happy Veterans Day.
Oh, thank you.
And I want to wish your listeners who may have served a happy Veterans Day as well. I think the history of physical therapy is not written without the contributions of military PTs. Mm-hmm. And so I'm grateful for everyone's service and wish you a good day.
Thank you for saying that. I really appreciate it. I will definitely put links in the show notes, ways that you can contact Todd, and yeah, thank you so much for coming on the show. Really appreciate it.
Awesome. Thanks for having me.
Thanks for listening to the Redefine Health Ed Podcast. Support our mission of getting more rehab professionals integrated into primary care by visiting redefinehealthed.com, subscribing to our email list, following us on social media at Redefine Health Ed, and taking one of our courses. All podcast listeners can save $50 on our Foundations for the Primary Care Therapist course or the Master Musculoskeletal Imaging certification by entering RHE Podcast, all lowercase, into the promo code section of the checkout page. Until the next episode, stay awesome, y'all.